Tonight's event is supported by Scottish Government, and PET is extremely grateful to them for their support. Donate, destroy or delay when IVF embryos are no longer needed for treatment. And I've sort of been thinking about this and thinking about how to introduce this topic, and I found it quite difficult actually, because when you embark on fertility treatment, there is a clear goal to have a baby, and everyone involved has that as their focus. And for you, it's quite rightly your main or indeed your only focus. You're not usually thinking, you don't have the headspace perhaps even to think that you may end up having to make a decision about what to do with embryos you may not need. But many people will end up with embryos that they won't need to use in treatment. And what to do with them is a hugely personal decision. So I just wanted to quickly rattle through the options for people in the UK of what they may do with their embryos. So you may donate unused embryos for others to use in fertility treatment, known as reproductive donation. You might donate your unused embryos for research, but this option isn't available to everybody because it depends on the links that your fertility clinic has with a research centre. Thirdly, you may donate the unused embryos for training purposes, or you may give consent for the embryos to perish. Or finally, you may delay or avoid the decision, perhaps until the choice is removed from you. For example, when your consent to store runs out, or at the very end of your storage period. And as someone who can be somewhat a serial procrastinator, I can identify with that. Now, we're very lucky that we are going to hear from 4 great experts this evening to give us really fantastic views on this and to have a good discussion. So we have Joanne Leitch, Kate Bryan, Laura Riley and Adèle Marston. And they're each going to give a presentation. And when they've all finished, we're then going to open it up for Q&A. So it gives me great pleasure to introduce Joanne Leitch. So Joanne is the lead clinical embryologist and laboratory manager at Glasgow Royal Infirmary's Assisted Conception Service and at the Glasgow Royal Fertility Clinic. So Joanne, I'm going to hand over to you now.
Thank you very much for inviting me to the PET event this evening on Donate, Destroy, Delay when embryos are no longer needed for treatment. I wanted to give an overview of a clinic perspective. And I've given this a title of The Fate of Genes, a clinic perspective. I wanted to give an overview. As an embryologist, we are often involved in the process of providing patients with information prior to treatment and prior to their consenting. And we're also often responsible for the system where we contact patients to let them know that their embryos, eggs or sperm still remain in storage. And to ask them what their wishes are. And quite often embryologists are the personnel within an IVF unit who have those discussions with patients at the end. So today's talk is going to be what we store, why we store, for how long, provision of information and informed consent, options that are explored before treatment and storage, what initiates a patient follow-up when they do have embryos or gametes in storage, the options that we explore towards the end of the patient pathway and to the end of the storage, and ultimately what happens. Do they donate, do they destroy, do they delay, and what is the fate of genes? So there has been special recognition about embryos and gametes. There is an act that governs the use of storage of gametes and embryos outside of the human body, and within the UK, we're regulated by a body called the Human Fertilisation and Embryology Authority. The storage of gametes and embryos is a routine and integral part of IVF treatment. Between 2013 and 2018, embryo storage cycles have increased by 700%, egg storage cycles by 240%. And I think what we're really seeing here is that we have seen an improvement in our culture, systems and techniques. We've seen an improvement in clinical outcome. We've seen an improvement in vitrification and warming methods. So we have an increased number of embryos that are now being stored. And in fact, frozen embryo transfers doubled between 2013 and 2018, and they account for about 40% of all IVF cycles. There is also a greater understanding about fertility preservation. So we are seeing an increased number of samples being stored prior to treatment for oncology or fertility preservation. And at the bottom here, it's just a table to say that the storage purpose and the permitted storage period. If you're storing for treatment purposes, it's up to 10 years as a statutory storage. There is a caveat with that. During the current COVID climate, the HFEA have allowed us to increase that to 12 years with patient consent. Fertility preservation can be up to 55 years if the individual continues to meet the requirements for premature infertility. And for donation, that can also be stored up to 55 years, and that is based on the recipient and if they are prematurely infertile and meet that criteria. And it is in 10-year increments that these assessments are made. So this is a cryo storage, typical cryo storage. We have a lot of samples and an increasing number of samples in storage. And there has been a consultation by the HFEA. Recommendations have gone to the Department of Health and Social Care about the statutory storage period and the likelihood of an increase from 10 years. So we do have samples in storage that are backup partner sperm. This might be that the partner is working away. It might mean that they have a very low sperm count or poor quality, and that there's a risk of the sample not being suitable for use on treatment, on the day of treatment, and azoospermic. We also have sperm that's been surgically retrieved in storage. This would be patients who are not producing sperm in their ejaculate, but there is an opportunity to surgically retrieve that sperm. That is then stored prior to treatment. We also do fertility preservation, so samples can be stored, egg, sperm or embryos before oncology treatment, before surgery, any type of treatment that might impact fertility, and also for trans patients as well. We also have eggs in storage that have been frozen, what we would call an emergency egg freeze, and that is there is an unexpected absence of sperm on the day of treatment. We also have samples in storage for donation purposes, egg donors, sperm donors. We have samples in storage for patients who are undergoing surrogacy treatment as well. There can be some requirements where either eggs, embryos or sperm are stored and quarantined before they're used in treatment, and that's to make sure that they're safe for use in treatment with a surrogate. And there can also be circumstances where you might have an ethical egg freeze, and that's patients who have an ethical concern about creating more embryos than they would ever use in treatment. There's two aspects to that. You can do a mild stimulation IVF cycle, which aims to produce a smaller number of eggs, or you can do a standard cycle to generate a number of eggs, and you would inseminate enough eggs to create the number of embryos that we would ever use in treatment, and the remaining eggs can be stored. So there's a number of reasons why we store and what we have in storage. Before we store and we treat, it is a regulatory requirement that we provide information and that the patients are given informed consent. So the Act requires appropriate information to be provided when an individual or a couple seeks treatment, storage or donation of gametes and embryos. Centres must offer counselling about the implications of proposed treatment, and we must also inform them about the role of counselling for emotional support. Individuals need to be given sufficient time to consider their options and their implications prior to consent. And embryos and gametes can only be used for an intended purpose with the consent of the gamete provider. And so what is informed consent? Everything that I have listed above helps to give informed consent. It needs to be given on a based, clear understanding of information that's been provided, the implications of their treatment, the consequences of the treatment, the risks and the benefits. The individual needs to have relevant information in order for them to make an informed decision and to give informed consent. And the clinic does play a really important role in this to make sure that the patients are fully informed. And we need to make sure that the information we're providing is clear, it's of high quality, that the information can be easily understood by the patients and individuals. And there are other tools that you can use. A lot of electronic consent systems now are in place where there are online learning tools that the patients can use to understand their treatment, and it is a really good platform for providing information and showing that the patient is understanding what they are consenting to. The options that are explored prior to treatment, they can consent to non-contact or contact research. They can consent to gametes being used to create embryos for their own treatment, partner treatment together, or in a surrogacy treatment. They can also consent to storage of gametes and embryos, and also what that storage period is. Whether they want their gametes or embryos to be used for training purposes. The use of gametes or embryos in the event of death or mental incapacity. If gametes or embryos can be used for training in the event of death or mental incapacity, birth registration and posthumous treatment. So that is if there are gametes or embryos in storage that an individual wants to use for their own treatment in the event of their partner's death, to have their details registered. Gamete for treatment of others, and that can be with or without the creation of embryos, and also for embryos that have already been created to be donated for use in treatment of others. And what really initiates the follow-up of stored samples? The patients may come to request to use in treatment. And quite often that will be the case if they've not had a successful cycle and they have samples in storage, and sometimes if they're looking to expand on their family. Also when it's approaching the end of the consented storage period, or approaching the end of the paid storage period. There may be a request from an individual to amend or withdraw their consent. This might happen if a couple separate. And it may be that they're removing their consent to their partner using the samples in treatment, or they may be removing their consent for the samples to be stored in treatment. There is guidance from the HFEA to say that there should be a 12-month cooling off period under these scenarios, as long as that doesn't breach the consented storage period. Or also death or mental incapacity of a gamete provider. There might be contact from a partner to understand what their options would be if they wanted to use the samples in treatment, or it may be that they've come to a decision that they don't want the samples to remain in storage and they don't want them to be used for their own treatment, and this is part of the pathway of closure for that individual. The options that are explored nearing the end of the patient journey might be that they have a definition of premature infertility, or they would like to explore whether they meet that criteria, and they may be eligible to extend the storage of their samples. There may be an intention to use in their own treatment. They may be considering donating to others or donating to research. Use in training. Or it may be that there is no longer a requirement for the samples to remain in storage. The patients do not want them for treatment or for any other reason. And I've got here that counselling is key. This plays a really important part of the discussions that you have with patients towards the end of their consented storage period. There is a requirement that the licensed centres have contact with these patients, but it's really down to the individual clinic as to how frequently they contact those patients. Most clinics would leave it at the longest a 12-month notice period, and that's to advise the patients that it's either coming to the end of a paid storage period or the consented storage period, so that the patient has enough time to have these types of discussions and ultimately decide what should happen to the samples that we have in storage. And as I say, counselling can be really, really useful, particularly if patients really are struggling with the idea of what will happen to their gametes, or what will happen to their embryos, and particularly if they're considering donation also. It's really, really important to sit down with a a registered, qualified fertility counsellor to discuss those options and those implications. So it goes hand in hand. And you'll be happy to know this is my final slide, and this is a clinic perspective of what my experience has been on what patients decide to do at the end of the journey of their stored samples. And do they donate, do they destroy, do they delay, and what is the fate of their genes? I have split it into two categories here, the fate of embryos and the fate of gametes, and this is just my perspective. It will differ from clinic to clinic. I obviously have come from an NHS background where there are no charges for storage at this point in time, and therefore quite often samples will remain in storage until the end of the consented storage period. So this is a snapshot of my experience and what I typically would see. You can see the breakdown here of use and own treatment, a request from the patient to perish, extended storage, donation to others, donation to research, did not respond. And I think that's one of the most difficult parts of this process, is often patients do not respond, and it may be that they are not comfortable putting in writing or making that final decision that the samples will be removed from storage. And it's not that these patients are lost to contact, a small number are lost to contact, but many patients, we know that we have the correct details. We quite often, clinics will have processes where they have evidence that the information has been received or signed for. And ultimately the patients have decided that they don't want to respond to make that decision. You can see that the split between the fate of embryos and fate of gametes is actually very similar. Slight differences in the fate of gametes with the extension of storage, and that might be because the majority or a larger number of the patients who have eggs or sperm in storage have stored for fertility preservation purposes and are eligible to extend. But I think what's very striking for my own experience, but I think there will be similarities with other clinics, is the number of patients and the number of samples that are removed from storage at the end of the consented storage period. It's 70 to 75%.
Kate Bryan is our next speaker, and Kate is a representative of Fertility Network UK, and she is the author of books including Precious Babies and The Complete Guide to IVF. She's a member of the Human Fertilisation and Embryology Authority, and she's the editor of the journal Fertility Counselling. But tonight she is very much speaking in her capacity as representing Fertility Network UK.
If you want to understand the patient perspective on embryos, you really need to start by thinking about the patient pathway through treatment and by appreciating what people go through and the role of the embryo to them. So from the very start, everything is focused on producing eggs. What's your ovarian reserve? What's the quality of your eggs? How many follicles are there? How many eggs? How many fertilized? So right from the beginning, there's a focus on these embryos as the hope for the future, as your potential children. And all of your choices are framed by that. It took so much effort, so much time, so much heartache, and often so much money to produce them, that there's a huge emotional attachment, and decisions about embryos are never taken lightly. Don't forget that many of us, like me, who are parents after IVF, first saw our children as embryos. So it's not surprising that to us an embryo is more than just a mass of cells. It's a potential child. You may not need them right now if you've completed your treatment, but they can still feel like an insurance policy for the future. It's a subject a number of former patients have written about. Here's Karen Tesler, writing in The Guardian, explaining why she decided to pay for another year's storage. Because not to pay means we're giving up our hopes of having another child and of giving my son a sibling. And that, to us, is a hard door to close. She quotes author Constance Shapiro, who says, "I had the experience of having a child, so the possibility that the other embryos could be children makes discarding them feel as if it's killing. It doesn't feel like they're simply embryos. It feels as if they're children wanting to be born." So people often feel guilt, anxiety, and sadness when they're trying to decide what to do. You might not want more children, but that doesn't mean that you don't want your embryos. So what do you do when you get the letter from your clinic asking you to make a decision? Donate, destroy, delay. Delay is often easiest, deferring the decision so you don't have to think about it. That's why, like Karen Tesler, some patients pay to store embryos they won't ever use. But what do you do when delaying is no longer an option? Sometimes, as we just heard, it's easier to ignore the emails and letters altogether, to leave the decision in someone else's hands. Apparently, it's so common, it's known as embryo abandonment. But it's really more about not being able to face having to make a decision when none of the options feels right. For patients, having to think about all this can take them back to the pain of infertility, to having to experience grief all over again for another child they're not going to have. The language used in clinics doesn't always help with decision making. Words like destroy or discard or even leave to perish are not easy for patients. Is there anything we could do to make the language feel less emotive? I'm not sure what's a better form of words, but maybe it's something we should be discussing more with patients. As one man said to National Public Radio, every time we read the destroy option on the form, my stomach does a somersault. It feels as if our future children are showing up once a year to confront us. So donating to another couple might seem the perfect solution. There's no destruction, no perishing, no discarding. And we may think that those who struggle to get pregnant themselves should be able to be understanding to others who need donated embryos to have a child. But this can pose difficulties. For a start, there are not many resources to help. This was a patient resorting to asking for advice on an online forum. I'm after some information on donating embryos. We have some frozen and would like to consider donating them to a couple, but I don't know where to start. It's not something people tend to have thought about. For some, it may be the perfect solution, but for others, the idea isn't so easy. Once you become a parent, donating an embryo to another couple can feel like giving your own child up for adoption, giving your children's siblings to another family. And the idea of your genetic child growing up with other parents can be challenging. This was a female patient, parent of 2, talking about the idea of donating her embryos to another couple. I kept thinking about our child growing up with other parents and I couldn't bear it. I would have wanted to vet them to make sure they would love our child the way we would have loved them, to be sure that they were going to care for them. And how would I explain it if the child came to find us when they were grown up? How would they feel that we'd chosen to keep their siblings, but to give them away? So, what about donating to science for research or training? This should be a really positive thing about helping other patients, about medical and scientific advances, about what we can all do for the future. But sometimes the information we give patients about this doesn't help them. It can feel cold and detached, focused on science rather than acknowledging the emotions involved, and may not really be addressing the needs of a patient who is struggling with the concept of donating embryos to science. For some, this goes back to the idea of the embryo as a potential child, to qualms about science, about mysterious experiments in laboratories. Donating to research or training can be easier if the embryos were never suitable for transfer, but it can be a challenge to think about giving a potential child to an anonymous researcher. Do we need to give more thought to the ways we talk to patients about research, to offer them more support with making such huge decisions? As Joanne mentioned earlier, counselling can be key here and can give patients an opportunity to think and talk about how they feel about all this. We also need to understand that even within a couple, both partners may not feel the same way, and that can make decisions even harder to deal with. People often feel badly informed about the possibility of having embryos left once they'd finished treatment. Should we talk to them more at the start of the journey? This can be difficult at a point where patients are not certain they will have any embryos, let alone being able to really think about having completed a family and making a choice about what they're going to do with embryos that are remaining. So what can we do to improve things? Would patients benefit from hearing about other patients' experiences? Would it be useful for clinics to provide case histories of the decision-making processes other patients have gone through and how they felt about it? Could we share more positive stories about the research involving donated embryos and about the advances they have helped to bring? The only way we will ever really know how to improve things, how to help patients make informed choices, is to talk to them. And I don't mean carrying out an academic research project or doing a patient questionnaire. I mean genuinely involving them in co-producing a better way of helping patients through complex decisions. We tend to have a very paternalistic attitude to patient care and reproductive health. Professionals decide what would be best for their patients, when what we should be doing is working with patients to ensure we do things in a way which would genuinely enable them to be better informed, to feel less overwhelmed and more confident about the decisions they need to make.
It was fascinating, and I was quite moved as well to sort of think about this and look through different patient lenses. And I think that's a point that you made really well, is that not all patients are the same, and not all couples will agree on what should happen to their embryos, making this even more complex and difficult for people. So next up, we have Laura Riley. So Laura is Head of Policy at the Human Fertilisation and Embryology Authority. Previously, she's worked in policy and ethics at Genomics England, at the King's Fund, and at the Nuffield Council on Bioethics.
Hello, I'm Laura Riley. I'm Head of Policy at the HFEA, and I'm here to talk about what the options are under the law for when IVF embryos are no longer needed for treatment. So the options are to donate the embryos for reproductive purposes, research or training. I'll let you know about some research support work the HFEA are doing at the moment. There's also the option of destruction of the embryo, and of course, and the title of the evening tonight, the delay. Making decisions about what to do with embryos can be very difficult, and we also aim to try to support patients around that. At the Human Fertilisation and Embryology Authority, we are the UK's regulator of fertility treatment and research using human embryos. We are working under the Human Fertilisation and Embryology Act, and we also provide a code of practice explaining the legal obligations of clinicians and researchers under that Act, as well as our licensing, monitoring and inspection duties. So if I cover reproductive donation first, under the Act, consent is a key thing for reproductive donation. You need specific consent for use of embryos in treatment for the storage of embryos. There also must be an opportunity provided for counselling and the provision to the donor of information about resulting children from reproductive donation and vice versa. So who's eligible to donate embryos for reproductive donation? There's age restrictions which differ between men and women, but the key point is that whether created with a partner, sperm or egg donor, there must be specific consent before an embryo can be donated. There's also a rule that not more than 10 families can be created by a donation for any specific egg or sperm donor. There's health screening that needs to be undergone, and you can't donate anonymously. There's a system of managed identity release for donation that we administer under the law, and there's also restrictions around the compensation that reproductive donors can receive. So embryo donors' rights, they're not going to be the legal parent of any child that's born as a result of their donation, but they can find out information about them. There's the number of children born, the sex of the children and the year of birth are available for them to find out within this 10 family limit that I've mentioned. Donor conceived people can apply to us to have information from our register if they were donated after the 1st of April, if the embryos that created them were donated after the 1st of April 2005. This just shows that this particular group's rights. At 16, they can apply for non-identifiable information. At 18, full details of their donor with name, date of birth and address. And at any time, the parents of a donor conceived person can request some non-identifiable personal information about the donor of their child. So research donation, relatively few embryos are donated for research, and as you can see here, it really varies between years. We don't really know why that is. So in 2008, you can see 154 embryos are donated for research. In 2015, there was a high of 1,187 donations of embryos for research, but in 2018, it went down to 721. We started a project between 2016 and 2018 to talk to patients and clinicians and researchers about what we could possibly do to smooth the pathway of donation for embryos for research purposes. I can tell you a little bit more about those outcomes in a minute. But in terms of the law, there's no age restriction or specific screening required for donation for research purposes. Obviously, research projects may have their own eligibility criteria, but it's really important to bear in mind that only 1 in 5 clinics actually have arrangements to recruit embryo donors for a research project, and there are relatively few research projects going. About 21 are listed on our website at the moment. Another thing to bear in mind is that you can only donate embryos to a specific named research project at the moment. So you couldn't donate your embryos to research in general to then be used by a specific project at a later point. So we ran a project between 2016 and 2018 because we wanted to essentially give more patients an opportunity to donate embryos to research if they wish to, and to support clinics in working with researchers as far as we could. So we reviewed the patient consent process, and we also looked at the license application process that we make embryos researchers go through, just to make sure there were not any kind of unjustifiable barriers or unnecessary burdens. So since then, as an outturn of the feedback we had from researchers, clinicians and patients, we've got new standard operating procedures around licensing and inspection around research. We've adapted our peer review forms to make sure that the license committee that will make a judgment about an applications for research license have all the information that they need. We've also collaborated with HRA, for example, on a briefing for NHS research ethics committees to clarify areas of responsibility that belong to HFEA to avoid any kind of duplication between the HFEA and the REC, which could cause delay. A really important thing that we're really pleased with is a partnership page, just a web page to facilitate collaborations between clinics and researchers. That was a new thing that came out of this project, because we wanted to make it really clear to clinics at any one time what researchers were actually looking for, so they can go to this page called Establishing Embryo Research Partnerships and look at who's doing research and what kind of embryos they're looking for. We continue to provide updated research summaries pages on our website, so that you can see the type of research that's being undergone for any specific research project, and we added a bit more detail as a result of this project. And we improved our information in general on our website for patients about donating to research in general. So this is just an interesting finding as part of that survey. That project, we did a survey, had a small number of responses, which were mostly from people who said they had already donated for research or they would consider doing it. So it's not representative of all patients, but you can see that you know, having the option to donate to research is important to patients, and we know this isn't available at every treatment centre. And there was also something for us, for the HFEA, to really think about amongst this group of patients' responses, that they also would be interested in generic consent to research donation. So that would be the kind of potentially kind of centralised sort of research embryo bank type of arrangement, not donating to a specific research project. So clearly in the UK there isn't such an embryo bank in operation at the moment, although we do sometimes hear of sector interested in establishing something like that. So to explore this further, we would definitely have to have any sort of discussion involving the sector and patients and researchers in great detail, but it was really interesting to us that that was viewed so positively by the patients who responded to this survey. We also, for example, heard back from clinics staff, and this again is a very small number of responses, 34, but it did show that they felt that even their own embryo research could be improved if more embryos were available, which was taking place at their clinic, which was interesting to see. And that, again, collaboration was a barrier. So we really hope that our webpage spoke to that group and helped them find out more about how to make a collaboration with a researcher to enable their patients to donate. Donation for training is a really important use of a donated embryo to enable embryologists to improve or learn new techniques, and specific consent is obviously required for this, but this is something also that patients can opt to do. Allowing embryos to perish, again, must be done with specific consent, and in that circumstance the embryo is withdrawn from the frozen storage and allowed to perish naturally in warm temperatures or water. Embryos destruction has to take place in the clinic. It's not something that can happen at home, and we do sometimes hear from patients who would like to take their embryos home with them, but this isn't able to happen. So delay, we know that storage periods are 10 years or could be less specifically, if considered specifically, but they may now be extended for 12 years. We know that the use of storage is increasing amongst the patient population. There's measures in place to have cooling off periods and obviously to contact patients before any embryos are destroyed at the elapsing of a storage period. But as I've said, we know more patients are likely to be storing embryos because we can see freezing cycles becoming so much more common, and we know that letting go can be very hard. So we're really pleased that counselling support is available at clinics. But the question of what should be done with stored embryos that patients won't be doing for their own treatment is already a pressing question for many people, because while treatment cycles increased by 12% between 2013 and 2018, storage cycles increased much more rapidly, increasing by 523% from 1,500 cycles in 2013 to just under 9,000 in 2018. So this question is affecting an increasing number of patients and will do in future. So we're really pleased that PET is covering it tonight, and we hope the HFEA can play our part to help clinics to support these considerations for patients. We have a leaflet on our website which clinics use with patients, which we'd be very welcome to, we would love to hear your feedback on, which sets out the options for patients, and we're going to continue to review the support that we provide to clinics around this area. Thank you very much.
Thank you, Laura, for sharing with us that regulatory perspective. And there's obviously quite a lot in there, and it's generated some questions already, I can see. So finally, we have Adèle Marston. So Adèle is Professor of Cell Biology at the University of Edinburgh, and she's Senior Research Fellow at Wellcome Centre for Cell Biology. So Adèle, over to you now.
I'm Adèle Marston, based in the Wellcome Centre for Cell Biology in the University of Edinburgh, and I'm going to talk about the option of donating unused embryos to research. So I'm going to give this talk from the perspective of my own research and how embryos that are not used in treatment help our understanding of infertility. So why is it important to study human eggs and embryos? And there's a real clinical need in female reproductive health. And as I'm sure most people know, the chance of a miscarriage by a pregnant woman is actually reasonably high, even at peak fertility, where there are more than 10% of pregnancies that end in miscarriage. And this increases exponentially as women age, so that by the time they're in their 40s, they really have a very high chance of a miscarriage. And overall, it's estimated that up to 40% of all human eggs are aneuploid. So it's also possible that aneuploidy, which is a condition where cells have too few or too many chromosomes, can arise from the sperm, but it's actually much more frequent in the egg. And as you see here, this increase in aneuploidy or miscarriages that you see is also derived from this problem in the eggs. So aneuploidy, which I'll get to a little bit more on the next slide, is what causes miscarriage and infertility. It's a very frequent cause of miscarriage and infertility. So what is aneuploidy? Well, aneuploidy is a condition in which cells have too few or too many chromosomes. And a normal human female has 23 pairs of chromosomes, as illustrated here. But it can also happen that if an egg or a sperm, which has the wrong number of chromosomes, fuse, then you end up with an embryo that has too few or too many chromosomes. And in most cases, this is not compatible, even with a small amount of development, and this embryo will be miscarried. But sometimes there are very few cases where this embryo can develop. And one such kind of aneuploidy is a condition where embryos have an extra copy of chromosome 21. You can see here, so this has 3 copies rather than 2, and this is actually causing Down syndrome. So where does this aneuploidy come from? Why is it that there are too few or too many chromosomes in some eggs or sperm? And this is due to errors in the process that makes the sperm or the egg, called meiosis, or indeed in the very early stages after fusion of the egg and the sperm in embryo development. So this is the normal situation. So we should have a sperm with 23 chromosomes and an egg with 23 chromosomes. These will fuse to form a zygote with 46 chromosomes, which can develop through many, many cell divisions to form the embryo, and then an entirely new human being. However, if there is an error in the process making the egg, called meiosis, then you could end up with, for example, an extra chromosome, 24 chromosomes. So when the zygote forms after fusion of the egg and sperm, you end up with 47 chromosomes. And in this case, this 47 chromosome embryo will attempt to go through the divisions, and it may make it to a stage where you have a group of cells, but very frequently at some stage prior to implantation, this embryo will be aborted and fail to develop. There is also the possibility that the egg and the sperm are made normally, you get a normal zygote, but then there is a later error in the mitotic divisions which produce the embryo. And if this happens in the early mitotic divisions, then you can end up with what's known as a mosaic embryo, where a few of the cells have the wrong number of chromosomes or are aneuploid. And it's actually very unclear what happens in this situation, but there is some evidence to suggest that this could be compatible with development, but we really need to understand more about this. So in our research, we rely on the generous donation of eggs and embryos from patients that consent to this material being used. And these patients will be undergoing IVF treatment for fertility problems. We are studying only eggs and embryos that are unsuitable for treatment at the moment, because and they're unsuitable because they fail to develop properly or in a timely manner, and so therefore not suitable. And normally in the clinic, these would be discarded since they're unsuitable for treatment. In our research at the moment, we're not currently using frozen embryos that are no longer required. However, this is obviously a very good source of research material if patients are happy to consent to this. And this is something that we may consider doing in the future. So in our research, we're really interested in these very early stages up to the 4-stage embryo. And as I showed you in the previous slides, we'd really like to understand what kind of errors happen in these stages and what the prognosis is for human development and miscarriages. So I'm just going to show you a couple of examples of the kind of experiments that we're doing. And this is a movie that was taken by our collaborators. So we work in quite a big collaborative project between the University of Edinburgh and the University of Warwick. And this is a movie taken by our collaborators in Warwick. And this shows the very first division after fusion of the egg and sperm. So this is a mitotic division. And what you can see here is that the chromosomes inside the zygote are stained with a dye, which allows us to see them under a fluorescence microscope. And you can see that these chromosomes collect together on what's called the metaphase plate. And then they start to move apart from each other at anaphase. And normally you should have an equal number of chromosomes going to opposite poles, so that the two new daughter cells will end up with exactly the same number of chromosomes. What you can see, however, if you just look a little bit later here as these chromosomes separate, is that there is what's called a lagging chromosome. So one chromosome is getting left behind. So there's already an error in this zygote. And It's unclear what happens when there is this error, whether it gets corrected and it ends up in the right place, but it could also go to the wrong place. But when the cell divides, so you see that the cell will divide along the middle, so that this group of chromosomes ends up in this cell and this group of chromosomes ends in this cell, there is a potential that this chromosome is in the wrong place. And we'd like to understand why that is. We can also look even in more detail at the positions of proteins that are actually on the chromosomes within the egg. And in this example, we're actually now looking earlier. This is just the egg before it's fused with the sperm. And you can see that this protein that's important in cell division forms these nice halos here. These nice halos here around another protein, which is actually part of the handle that the cell uses to pull the chromosomes apart. So through our research overall, we hope to understand the origin of human aneuploidy, and we hope that this can eventually provide better choices to patients. So I just want to finish by thanking especially all the patients that have generously donated their samples to us for our research, and the embryologists and clinicians at the Edinburgh Fertility and Reproductive Endocrine Centre who have really been helpful in getting this project underway. This is a fantastic collaboration between researchers here in Edinburgh and researchers at the University of Warwick. And I'd also like to thank the Wellcome Trust in particular for funding.
We've got lots of questions and I'm going to endeavour to direct them to one of you to answer first. So I'm going to go with the question, and I think that the most popular question is actually for you, Laura, which is, why can't patients take their embryos home with them and allow them to perish in a respectful way of their choosing? And that's something that's come in from Olivia Montuski. And actually, it was something that I was, it was the most bizarre tube conversation I've ever had with a patient after an event, but she was telling me that that was what she'd wanted to do, and was very upset that she hadn't been able to do it. So if you want to go on that first, and then perhaps Joanne can follow on that one.
Thanks, Sarah. Hello. Yeah, I mean, it is something that does come up occasionally from patients directly to us, and obviously it's very hard when people's wishes aren't able to be fulfilled. I'm afraid that that's a legal restriction, not something imposed by the HFEA. So yeah, I mean, and certainly in other scenarios, we know that, for example, with fetal tissue, that there can be arrangements made after an abortion to take home fetal tissue via an appropriate arrangement, you know, with an undertaker. So actually there are other examples where there's been thought put into this, and there have been arrangements that allow women to make choices that they feel most comfortable with. So we're certainly listening to this, and but unfortunately it's not in the HFEA's gift to make a change. The arrangements are in place at the moment.
I'm sorry to just put you on the spot there, Laura, but is it actually in the Human Fertilisation and Embryology Act, or is it in something more to do with tissue? Would it be in the Tissues Directive or something like that?
It's in the HFE Act, to my knowledge. Sorry, I couldn't point you to the exact place, so that's my sense of where it comes from, is the HFE Act.
And Joanne, did you want to come in on this?
It's certainly something that patients have discussed with us, but for me personally, it's been certainly a minority of patients have requested that, but I completely understand why this would be a request of patients, and you would imagine not it doesn't seem like an unreasonable request for a patient, but if it is in the Act, then unfortunately it's not in the clinic's gift to do that either.
Does anybody else want to come in there? Kate, did you have anything to add there from a patient perspective? Is it something you've come across?
I think it's something that could possibly help some patients. I mean, obviously it's not something that everyone will want to do, but I think for some patients it could possibly help with a kind of grieving process, feeling that they could have some kind of ceremony for the embryos.
Okay, I wasn't going to go to you with to you, Adèle, on this one, unless you've got a burning point to make. But move on to the next question, which is also from Olivia Montuski and also extremely popular. And this one, she's directing to you, Kate, in the first instance. And so in the US and New Zealand, it's possible to donate embryos to a known couple so that the families can remain in touch with each other and all the children known to each other as siblings. Olivia thinks this feels like a more humane and child-centred option. How do you feel about this?
I can imagine it's something that might be really popular with some patients. And from the quote from the patient that I gave you earlier, one of the difficulties was about not knowing where the embryo was going, not knowing who it might be going to. And I think sometimes that can be a barrier for patients. So I think it's a really interesting idea. I understand why at the moment it would be quite problematic given the legal situation that we have. But I think from a patient perspective, that could actually be a really positive move for some patients, not for all.
Okay, does anybody else want to come in on this? Have you been requested, have people spoken to you about this in clinic, Joanne, or is it?
Not specifically about meeting to an individual or a couple that they know. We are experienced with perhaps an individual being a known sperm donor or perhaps being a known egg donor, but certainly not embryos. It's not been a frequent or a common request in my experience, but I can understand why that option might be appealing to patients, particularly with how they feel and how they personalise their embryos. So no, I can understand why that would be an attractive option for patients.
Okay, I'm going to move on to the next question, which is for you, Joanne, which is what happens to the embryos when a patient does not respond to clinics contacting them regarding the end of storage? Are they left to perish, destroyed, and who makes that final decision for the embryos?
Yeah, unfortunately, it is difficult, and it's difficult for embryologists because they are the individuals who are actively removing samples from storage. And because we are performing that, it's much easier for us if we have clear instructions from the patient as what happens to those samples. And that, under those circumstances, it's very clear instruction, and you know that you're carrying out those patients' wishes. If you have a patient who's lost contact or a patient who has not responded, then you're legally bound to remove those samples from storage at the end of the consented storage period. And patients are counselled on this. These are the discussions that we have with patients before they have treatment, before embryos are stored, before gametes are stored. And it's also information that's provided when we then contact the patients to follow up. So they are, in a sense, aware that that is what will happen at the end of the consented storage period. And I think it is just, for a lot of patients, not having to make that final decision and it being taken out of their hands and that decision being made for them. I think there are so many patients who don't respond to the contact that I think perhaps for them that's their preferred option.
Yeah, I think that's something I sort of alluded to in my introduction as someone who's a serial procrastinator. I can imagine with those sorts of difficult decisions that would to some be the preferable option, but I think it does put a huge burden on the clinic, and I can understand that from your perspective, to make sure that you'd want to make sure you've done absolutely everything possible to make sure that they hadn't just missed something in terms of communication from you before you did that. But then you'd be in trouble with Laura if you were storing them without consent, and you'd have difficulties with the HFEA. So it is quite tricky. So the next question is from Fran Farley, and I'm going to say this is for Laura, but I'm going to bring Adèle in this one, I think, as well. And that was, would some of the drawbacks to having I think she means what would be some of the drawbacks to having a generic donate to research embryo bank. It seems like something that would help both patients and science. So what are the factors that are delaying this option? So I think if you start on that, Laura, and Adèle, perhaps you talk about, then follow on how that, whether an embryo bank would be a good idea from your perspective.
Thanks very much. Yeah, so obviously with other forms of tissue other than embryos, there are biobanking opportunities available for research purposes quite often. We have considered, obviously, very carefully in thinking about this at HFEA, you know, the special status of the embryo, which Warnock highlights, and obviously the Act as well. So our assumption has been that having a kind of specific project that would take a patient's embryos could be, for some patients, a very important part of wanting to donate to research at all, because they'll know exactly to what purposes it, you know, the research is aimed to sort of help with, and what exactly will be done with the embryo as part of that research. So that's kind of been a really sort of guiding thought with us. I'd imagine from the clinic perspective, an advantage of the kind of specific consent model we have at the moment is that also in terms of things like storage capacity or storage costs at a clinic, if you've got an arrangement that's already in place with a specific research project to transfer swiftly the embryo sort of from clinic to researcher, that kind of works quite smoothly. So that's kind of some pros perhaps of the specific consent model that we have at the moment, but obviously there are huge drawbacks, as people are noting. You know, it relies on clinics having collaborations with researchers, relies on there being specific research projects available to take an embryo, and not all clinics have those collaborations. We are trying to help with that, but you know, that's still the case. And that means, unfortunately, the opportunities to donate, that option isn't available to every patient. Clearly, not all patients would want to take it, and not all patients would probably want to contribute to a biobanking model either, if that was available. But you know, these are all really important areas to explore, we think, and certainly we are thinking carefully about that, and we'll be keeping an eye on whether, sort of considering we try to make these sort of changes in response to what clinicians and researchers and patients have told us around donating to research, sort of we'll be keeping an eye on how the numbers of embryos being donated to research are going sort of over the next few years, and wondering again, you know, having a look whether consent could be a way that we could improve those choices for patients, and think about this kind of potential biobanking option again in future.
Adèle, do you want to comment?
I can say a few words. I mean, I think there's no doubt it would be a very useful resource for researchers, but I guess one key thing is that the sort of timing of when this would happen, and the time when the researchers would use the embryos may be quite different, or quite a lot later than the time at which the patients are given consent. So whether you would need to go back to the patients and ask them again, or how patients would feel about giving consent for something that might happen in 10 years' time is maybe something that would need to be thought about, I think. And again, you know, the procedures that we use in 10 years' time might be quite different from the kind of science and the research that we can do now. So it's quite difficult to actually give patients exact details on the kinds of methods that we would use on the embryos in 10 years' time. So I think it should be discussed, but I'd like to know what the patients think, actually, personally.
Yeah. I mean, Kate, have you thought about that at all, about this sort of generic and specific consent to research? Is this something that's come up much in patient discussions?
No, it's not something that's come up much in patient discussions. None of this comes up very much in patient discussions, to be honest. But I think it's really important, as Adèle just said, that that we do find out what patients actually think about any move to do something like this. I think that there are some patients who would actually really, really like to be able to donate to research, and it's a real shame if they don't have that option just because their clinic doesn't have that option. So I can see that there would be some advantages, but other patients would really want to know specifically what's going to happen to their embryos and what exactly it is that someone is trying to find out using them. So I suspect people might think differently about it, but that's why we really need to talk to them and to find out what people do think and what options might be good to be able to offer.
Yes, and I think after the difficulties, shall I say, that we've had around people putting conditions on gamete donation this week in the media, you can imagine it could be another whole level of complication and potential, inadvertent error here, and that would be extremely problematic. So, I think, as you've all been saying, it's sort of a noble principle, but quite difficult. Sorry, Joanne, you're waving at me.
I'm going to ask a question to Adèle. If there was a bank of embryos that could be used in training, do you think that would increase the potential for research within the UK? Is it a bit of a chicken and egg?
I think it would, yes, because I think it would give a reliable source that people could go to and know that there would be embryos available, and you would be able to do a particular experiment on a particular day because there would be this ready source of embryos. Whereas, right now we basically wait for a day when we never know actually whether we're going to get embryos or not. So we have to be quite flexible, which in the current situation is getting more challenging, right? Because access to labs and everything is not as easy as it was before COVID, basically. So yeah, I think it would be a great resource, and I think it would increase the kind of things that people could think about doing.
I've just noticed that there's a sort of a follow-on question, actually, and comment from Kathy Nykan, who is a researcher in this area. And Kathy says there are fetal banks, which is also a very sensitive area. And polling of the patients by the HFEA showed 70% who responded preferred a generic consent. So why not give patients more options and give them the option to consent either to specific or generic consent and let them choose? I don't know I can see nods, and we've sort of covered it a bit, but I sort of wanted to get Kathy's view in there. Does anyone want to come back on that?
That sounds very sensible.
Yep, thank you, Kathy. You might have come up with a potential solution. So there's a question next about language, and that was something that Kate raised, and it comes up a lot at our events and so this is from Deborah Howe, who says, I have a strong sense of the power of language and terminology we use in the fertility arena, and if we're sensitive, if we are to use sensitive language to patients, I think we need to try to and standardize it throughout, but I'm unsure how we can do this. For example, and I'm hold my hands up because I think this came from me, the title for the talk tonight, which is fascinating, but it uses the word destroy in its title. So Kate, you sort of very modestly, I think, perhaps said that you hadn't sort of really come up with any terminology, but I know you're great with words. So I did wonder if you got any sort of things that you could float, at least to sort of get the conversation going.
I genuinely don't, and I think sometimes euphemisms are actually worse, and it would be disastrous to come up with something that sounded terribly twee that was actually, distracting from the reality of the situation. That is why I think we really need to talk to more patients about how they feel about the language and what they feel might work and what they prefer, because it's only when we start talking to lots of people that we really get an idea of how people feel about it. I think destroy is never a good word and is never going to be a good word for this situation. I don't know what the right term is, though. I really genuinely don't, and I'd be interested to know if anyone else has a really good idea, because I don't.
Joanne, have you alighted anything in the clinic when you're having these conversations with patients?
I mean, I completely agree. Trying to find the right terminology, and it's individual to the patients as well. We tend to use the terminology perish because we feel that it has less connotations than destroy. We can also talk about removing from storage and humanely discarded, but also the discarded has connotations. So it's difficult. It is difficult because, as you see, these are patients' precious embryos or precious gametes. And yeah, I don't have an answer, I'm afraid. I've got options, but I don't have the perfect answer. And I think you're right. I think those discussions with patients and getting that feedback, I think, is important, and how we then shape our terminology and how we have these discussions with patients. Yeah.
I have to say I'm usually a fan of, you know, quite direct language, but I do appreciate, you know, that not everybody is, you know, everybody is the same, and, you know, and can find that very, very difficult to do. And I don't know whether Laura, the HFEA, has done any work around this, about thinking about the language here or not.
I don't think we have specifically. We do discuss it as an option on our website, and the content we put on our website is reviewed by a small panel of patients, but we haven't specifically looked at the language around this. But I think this is raising a really important point. Yeah,
I think a few people have commented in the Q&A now about this, and someone, Bay Osmani, saying that they've had patients upset by the term discard and allowed to perish seems to be better and perhaps the most common approach. I think someone else has suggested let go. Sorry, that's Rachel Balby, and she says that's a phrase that puts the initiative to the patient and can also be used across the different choices. Someone else, Paul Collins, said an abortion is known as a termination. Why not use the same terms? I don't know how patients would feel about that, about the termination of an embryo. I don't know whether I'm convinced about that. I don't know what the panel think. So unless anyone wants to come back on that, I'll move on to another question. And I think it's slightly off topic, so I'm going to miss that most popular one. So this is a question from Emily Engel, and it's for Joanne in the first instance, which is, do clinics still have the option of different baselines for storage? And I think, so one clinic I know used to only ask for consent for 3 years in the first instance. And so a woman with a 2-year-old egg donor child wanted to try for a second, but the donor wasn't then responding to requests to extend storage, which then had been stored for over 3 years. The egg had been fertilized, so it was a full sibling to the first child, but she wasn't allowed to use it. Presumably the donor, who'd been an egg share donor, was busy with a toddler of her own and unaware of the consequences of not replying to the clinic's letters. This seems to have been an avoidable tragedy. Why didn't they use the 10-year storage as a default for the consent?
You know, there is quite clear guidance from the HFEA when it comes to consent periods, that the clinic can influence a patient on the number of years that they should be consenting to. There's obviously a statutory storage period that patients can consent up to, but it really is down to the individual patient, and this comes back to informed consent, provision of information. If you are talking that process through with a patient prior to treatment, you should be giving them as much information and as clear an information as you possibly can. And I think if in the instance of an egg sharing, then those types of scenarios should be discussed when the gamete provider is placing a number of specified years of storage. But ultimately, if the gamete provider has wanted to limit for whatever reason, then it's perfectly within their right to do so. But that should also be discussed with the recipient, that there is a limited storage period on either the gametes or the embryos, so that when they are using them in treatment, then they can make decisions about their treatment and about the use of those gametes or those embryos. So again, it comes down to providing appropriate information to the appropriate people about the treatment.
Is there anything else that any of the panelists wanted to add to that? I think Joanne's pretty much covered it. So I think then there's a question for Adèle. So in the in view of the high miscarriage rate in nature, should there be more information and education about this? In my experience, many women have never considered the possibility of a miscarriage, and nature doesn't seem to be very good at nature does seem to be very good at getting rid of what they put in scare quotes, faulty embryos. So Adèle, if you want to do that, and then perhaps I think Kate might have something to say.
Yeah, I mean, I think it's definitely not part of the sort of sex education that you get in school. It's sort of more the opposite, you know, how not to get pregnant, right? Whereas, you know, I think it is something we should be talking about more. And I think one of the things about it as well is that people really don't necessarily like talking about it, and they're embarrassed when it happens to them. So I think one of the things that we want to do sort of alongside our research is just try and have a more open conversation also with patients about why there is such a high level of infertility, and that it's really not anybody's fault. It's just kind of the way humans are made. And I think that, of course, PET plays a quite important part in opening up conversations about this as well. So I think this is a good thing, and there should be more of these kind of events, and it should be more of a mainstream conversation. Yes, I agree with that.
Did you want to add anything in there, Kate?
I think it's really true that we don't talk about it enough. And I think one of the things that doesn't always help with that is the fact that we tend to be told not to tell people you're pregnant until you're 12 weeks. And so people don't feel that they should be sharing because of that, which can make it really, really difficult. And I think people are often not prepared for how incredibly distressing an experience it can be to go through a miscarriage either. I mean, physically, emotionally, in every way, really. And I think also not knowing why it happens can make it really difficult for patients too. And the fact that, you know, it's not often investigated until they've experienced recurrent miscarriage. You know, we just sort of talk about it in very vague terms. We don't ever really think about what it's actually like for people to go through this, and the loss and the sadness that people experience. But I would really say to anyone who does go through that the Miscarriage Association is absolutely a brilliant support network. So do get in touch with them.
Yeah, I definitely second that. That's yeah, very important support group. So we've got a question from someone who wishes to remain anonymous. I've heard of an option of transferring embryos when it's known that it won't result in a pregnancy, so out of cycle in the US. Is that something that's available anywhere in the UK? Compassionate transfer or something? Because this could be another option beyond the donate, destroy, delay. So I don't know who wants to take that one first. Joanne, have you ever been requested at the clinic to?
No, we haven't, but again, it probably comes down to provision of information. It's not something that we would offer, but I am aware that it does occur, certainly within the US, or that they're placed either at the wrong point of the cycle, or in the in an area where it's not going to implant as well. I'm not sure what my thoughts on it are, if I'm being perfectly honest, because it's not something that I'm familiar with within the UK, but I'm not even sure if the HFEA would have an opinion on that.
I think that sounds like the perfect cue to bring Laura in. Laura.
Yeah, that hasn't I haven't experienced that at the HFEA, I'll be honest. Sorry, I couldn't tell you our view on it right now, but I think obviously for a clinician you'd have to sort of weigh up the intervention that the woman's undergoing unnecessarily and any increased risks to the woman of providing that procedure. So sorry, it's not a clear answer from me.
Now, I have one of my dim recollections. Is this something that does anyone know? Is this something they used to do in Italy when they had to not have any embryos left over, or was that because when they sort of really egg freezing rather took off, so they didn't have surplus embryos in the first place? I think I might be getting those conflated. No doubt someone will correct me in the Q&A. So we're getting towards the end of time, so I better stop. Concentrate on questions. So there's support for your case history idea, Kate, coming in the Q&A, and people think that's a good idea. A question for Laura. Does the HFEA know how many embryos and gametes are in storage in the UK? I feel this might be a quick answer.
Gosh, I'm afraid we don't have that snapshot immediately available. I mean, I can tell you in the last year for which we have data available, 2018, about 7,000 embryos, frozen embryos, were stored. And that's a really big increase. That's about a 700% increase if you look back at the 871 that was stored in 2013 in that year. But I'm afraid I couldn't give you a kind of cumulative number for all of the stored embryos in the UK at the moment.
Okay. I don't think I'll put that to anybody else. I think it was just one for Laura. I think this is sort of a bit of a sort of pointer for Adèle. It's more of a statement than a question from someone else who wishes to remain anonymous, which is, I donated my embryos to research but heard nothing from the clinic as to which research or even a letter, and I felt I was left dangling, not knowing the outcome or even if they were actually donated. And so I wonder what processes there are in place to put information back out there to patients, even if you can't. I don't know what the provisions would be for contacting them directly, but just a sort of generic.
I mean, my understanding is that that when patients are consented, they are told that they will not get specific information to their case, and I think that patients should be told that, because we actually don't know anything about the identity of the patients. As researchers, patients are completely confidential. All their information is kept at the clinic. So it would be quite difficult actually to trace back our findings to individual patients, and it's designed, from our point of view it would. So it's designed that way to protect the anonymity of the patients. But there should be some general information available about the project as a whole. And it's a pity really that that wasn't made available to you, but you probably would just need to know where to look, I think. We are intending to, I mean, our project's still quite early days, but we're intending to set up a website that will have sort of generic findings from our study, but not for specific patients. I think that would not be appropriate, actually.
Yeah. Laura, did you want to come in on that or not?
No, just to echo what Adèle said, it'd be really helpful, and sometimes projects provide kind of newsletters that you can sign up for to sort of passively receive an update of information at regular points. So that kind of model might be helpful with this, perhaps.
That's a good idea. Thanks.
I'm just starting to see if I can find one more question, so we can quickly squeeze it in. So there's somebody else who wants to remain anonymous. So there's a huge amount of work involved in contacting patients to ask them what their wishes are. Is it fair on a usually overstretched clinic to constantly contact them when the couple has no intention of using those embryos, probably? It's a huge strain on resources that could perhaps be used to provide further cycles. So, Joanne, do you want to go on that one first as the person in the clinic?
Come in my direction. It is a huge amount of work. It's a huge amount of administrative work managing a cryo storage and a cryobank. Contacting patients to advise them that either a consented storage period is approaching. It's down to the individual clinics to decide how they operate or how they manage that, as the HFEA call it, a bring forward system. And it can be very laborious, but it's a regulatory requirement that we contact these patients. I'm not sure that there is an answer. Perhaps we can think of better ways of engaging with patients to perhaps follow up with that communication. I think certainly COVID has put into the spotlight the methods that we've been using to contact patients. We've perhaps been using paper-based systems. The patient population that we tend to treat are, I would say, a younger generation, and perhaps looking at methods of electronically contacting patients might improve the response rate. I think it's looking at ways that you can improve the engagement I like the idea of improving the options that are available to patients. If there was a generic research, perhaps more patients, if they felt that that was an option that they could choose, you might get more of a response from them. But ultimately, and certainly from my presentation, there are many embryos and eggs and sperm that remain in storage towards the end of the consented storage period, and 70 to 75% of them ultimately are removed from storage at the end of the consented storage period. So it's a lot of administration. It's also the storage upkeep of them. It's that they have to be externally monitored and alarmed. You know, your embryologists are on 24-hour on-call systems in the event that anything goes wrong. So there are a lot of resources that go into maintaining a cryobank, and I think, despite the fact that it's a regulatory requirement, I think, you know, there's an ethical and moral requirement that you contact these patients, that you make every effort to be in contact with them, that you document the efforts.